Welcome. So today's meeting of the HHC Accountable Care Organization Sole Member Annual Meeting for calendar year 2024 is now called to order. So for the record, please note that Shari Shamani is representing Dr. Michelle Morse and Karen Sanhilaire is representing Molly Wasso Park, all in a voting capacity. Next on the agenda is the adoption of the minutes of the HHC ACO Annual Membership Meeting held on November 30th, 2023. Are there any questions, comments, or suggested changes? So may I have a motion? All in favor, please say yes.
Yes.
Those say no, so minutes approved. So next on the agenda is a resolution for the annual election of the officers for the ACO. So Mr. Ziegler, can you read the resolution into the record?
Sure. Good to see everyone. Authorizing that each of the following persons be elected effective immediately to serve as a director of HHC ACO Inc., the ACO, Board of Directors in accordance with the laws of the state of New York, with the names listed below. There is one change just from last year, which is Dr. Joan Curcio representing Mount Sinai. Otherwise, the membership has remained the same.
Any questions from board members? Hearing none, then all in favor of approving the resolution, say yes.
Yes.
Opposed, say no. So resolution approved. Thank you so much. So Mr. Ziegler and Dr. Okolo will provide now an update of the activities of the ACO. Welcome.
Thank you for having us. Great to see everyone. We'll first update with some changes to our team and additions to the ACO. Dr. Okolo, who is a practicing primary care and geriatrician at Kings County Hospital, has been working with the ACO and is now our medical director.
Oh, okay.
And Megan Maher, who many of you may know from our finance committee meetings and leads our managed care team, is joining for part of her time as the chief operating officer of the ACO. So it's going to be a great step to bring all of our value-based care programs together more seamlessly and continue to make great progress on the work we've been doing. So we'll take you through our performance and some of the results we recently received. For the 11th year in a row, the Accountable Care Organization has generated shared savings, meaning we have helped reduce the cost of Medicare spending for our patients while maintaining very high quality. And so we've earned a performance payment of over $6 million, and we'll be distributing that to our primary care providers and care teams around the system early in the new year. So we're very excited about that. And pleased with the continued progress. A little bit of detail on how we think we're going to perform next year, because we are well into 2024 and waiting for our final results. We think we will generate our 12th year of shared savings in a row, which is a tremendous record and we're very proud of. We're consistently performing below the benchmark, and we think we will not owe money back to CMS and will be again in a position to distribute shared savings to our primary care doctors and care teams around the system. Just to update you on the program itself, then I'm happy to take questions and talk through a number of the clinical initiatives we're doing and how we're having this success. But as you may remember, the ACO program has a number of different tracks. We're in the enhanced track, the kind of high risk, high reward track, where if we don't perform well, we could owe money back to the federal government, but if we perform well, we have a lot of earnings to potentially distribute to our providers. And our current contract ends at the end of this year, and so we applied to continue on that same track for another 5-year period. We can leave in the course of the contract if there are changes in policy or changes in our performance that no longer make it advantageous for us to keep going, but we expect we'll remain in through the 5-year period. The slides have gone dark, and I have been following our printing saving guidelines, so I don't have it on paper in front of me.
We do have it, and someone did follow the guidelines because it's all black and white and not the expensive banner that is so bad for the environment with the colors. So
Wonderful.
we're very pleased.
Well, another gold star for the ACO team. That's what I'd love to hear. And Dr. Colo can speak to it in more detail. We had a good, modest but good improvement in our quality scores last year. So the ACO program, again, is not just about reducing unnecessary spending in the Medicare program. It's about doing it while you're maintaining or improving quality on a number of key measures. And so we had some improvement overall there, and we're very pleased about that. A lot of good alignment with the other clinical quality efforts we drive around the system, and we will dive into that in a little bit as well. Happy to take any questions on the financing and the overall status of the program, or Dr. Okolo is going to take us through some of our key clinical efforts through the ACO and the team. Yes, sir.
Yeah, could you just remind me exactly how have you been distributing the excess?
Yeah.
How do you go about that? What's been the, I guess, the theory about how best to distribute it?
Absolutely. It's been, as you noticed from our board of directors, there are representatives of each of the affiliates across the health and hospitals facilities. The methodology has been 40% kind of a flat amount based on the amount of membership and patients that are at each facility, and then 60% of the amount based on the facility's quality scores on each of these different dimensions. So generally, we take off the administrative costs that the ACO runs. We have put a certain amount aside for reserves to make sure if we ever do owe money to CMS, we're able to pay. And then the about 80+% of the shared savings goes directly to providers, and another 20% or so goes to care teams as a kind of broader care team fund to support quality improvement activities, incentivize and encourage the non-physician partners on the team. And so there's about a $4,000 spread between the highest distribution to a provider and the lowest. And they have over the years ranged from, I'd say, about $30,000 to $10,000 in distribution per provider. So a meaningful amount we're very pleased to distribute.
And is it broken down in such a way as to somehow enhance those who have done well with the quality scores as opposed to those who've done less well? And how does the, I guess, the economic piece, the cost factor go into it as well as far as utilization? How do you have any method of trying to reward those with low utilization, highest quality versus those with high utilization, poor quality?
I'd say relative to other ACOs around the country, we are relatively uniform, right, in our distributions. So the shared savings is largely split by membership across the facilities, not individual surplus at the facility level. And then the quality scores are done at the facility level rather than the individual physician level. And part of that, as you know, the total membership of the ACO is only at this point about 6,500 members. So you get to quite a low sample size in some cases, and we want to encourage quality primary care around the system, and having wide spreads based on such a low sample size has always felt, I think, difficult for us as a management team and for our board as well. So that's generally where we land on that.
Just a quick follow-up question to that. How do you decide when you want to increase the size of ECHO bringing in new membership? How do you decide when to grow and how to grow it, I guess?
Great question, and I'd say a very timely one. We are there are different ways to assign members to the ACO. It's generally not something that you market to people and they sign up for.
Right.
They are prospectively attributed to it. They're all Medicare fee-for-service members. And so it's really a matter of how many Medicare fee-for-service members are coming into our system for the majority or predominant amount of their care. And so the methodology to kind of grow our ACO would be marketing to more Medicare members and bringing them in some form or another. Generally, the balance has always been Medicare Advantage, which Metro Plus and Health First and others offer, is growing very substantially around the country and in the city, and Medicare fee-for-service is relatively shrinking. So we have felt that trend as well. Because of the kind of positive performance we have in Medicare Advantage, we haven't really sought to stop our growth in Medicare Advantage and advantage ourselves on the ACO side.
Great.
And, I think that's probably still the correct strategy, and the trend we'll see continuing to play out. But, as we dip down below 6,000, 5,000 members, it's challenging to generate shared service. It's a small sample size, and we'll have to see if there are changes in the ACO program in the new administration that seek to grow it or seek to advantage Medicare Advantage more. It's interesting to watch.
Overall, the leaders who've been chosen for the next administration are very big Medicare Advantage people.
Yeah.
So the likelihood is that it will not grow. It will continue to shrink as a population, for good and for bad. Lots of, the big debate is Medicare runs at 4% admin. Medicare Advantage runs at about 10% admin. And there's a lot of concern as to whether or not there's upcoding among the Medicare Advantage, or at least upcoding would be the negative word. Better documentation would be the neutral term, that people document to get a higher risk-adjusted rate. And so, what the federal government loves about Medicare Advantage is it's predictable. Governments love predictable, right? Because it's a rate. So you know at the beginning of the year what you're going to pay. Whatever you've decided the rates are times the number of beneficiaries. Fee-for-service Medicare, you don't know. It depends on who goes and what they get, and so this has been there are a group of policymakers very pro Medicare Advantage, and there is a small but loud group very negative about Medicare Advantage, who argue that it's a waste of money on administration that does not equal better value, and a bunch of data studies, some of which support better value with Medicare Advantage and some of which don't. So sort of whatever you believe at the moment.
The administration cost is the federal government's cost, or?
Yeah.
Yeah.
So the federal government obviously is paying, right? There's no state or city contribution in any Medicare program. It's 100% the federal.
So it's certainty, but at a higher cost is sort of.
Well, yes, it's at this moment. I mean, and again, these things are so complicated. The administrative cost is higher, but some people would argue that because you're managing the care, the overall cost will go down. An example that irritates us very much is that if you have Medicare fee-for-service and you're, say, at Bellevue and you need rehab, you're going to go the same day, because people want fee-for-service Medicare lives at their rehab today. You call today. Same person has Medicare Advantage. Well, you can't go today because your Medicare Advantage has to approve your stay. And you can't go anywhere. You can only go to the ones that your Medicare Advantage has contracted with. So one of the immediate savings that Medicare Advantage, in my mind, provides is usually 2 days of free care, because the hospital is paid on a DRG under Medicare. So if your DRG is hip fracture, you're going to get paid hip fracture. That's how it works. So there's no payment for the extra 2 days that you're staying in the hospital, and while your Advantage plan is reviewing, approving, and deciding where you're going to go. So a lot of the criticisms about the quote-unquote savings under Advantage plans are, yes, they get to say no to certain kinds of inhalers, they get to, slow your movement to rehab, and there are the savings. And whether those are real savings or just, changing who's paying. Right. But that, if you believe, so the true believers in it would say, no, it's not just the certainty, it's by managing the risk that you will lower the federal bill on Medicare. But so far that, I think what the data, which is so far overall, that hasn't happened. Overall, the Medicare Advantage people have not shown themselves to be cheaper. But again, it's self-selected, so that's yet a different issue, how people get recommended. I tell people if you've got enough money in the bank, take Medicare fee-for-service, get to go wherever you want. Nobody's going to tell you what to do. You're low in money, and that 20% might be very expensive for you. Take Medicare Advantage. So as soon as you realize that, then it's very hard to compare because you're getting two different populations in Medicare fee-for-service versus Advantage. Do you want someone managing your care? Some people do, some people don't. So then that's the other, you'd say, okay, this has been going on for a long time. Why can't we all agree that one is better by looking at the data? And part of the answer is because it's self-selected. And so even when there are differences, then people argue whether the differences are due to the differences in the program or the differences in who signs up for which program.
And when did Medicare Advantage really take off? Is it the last,
I think when Matt was working in the White House.
2013 was, I'd say, when it really got going, and then the Affordable Care Act has, strengthened it and expanded it. Yeah.
But like the ACO, right, you said is all Medicare fee-for-service, and we're,
Just
like
a
the
small
quality
number.
that we're, what's that?
It's a small number.
It's a small number.
What's the Medicare Advantage in the system?
At H&H,
Yeah, what's the proportion? Because you said it was, right?
I mean, we're close to 100,000. I think,
Right, so
across
it's
Health
60
First. Metro Plus is quite small, but the Health First membership in Medicare Advantage is quite large.
Like 25,000.
Go ahead, Jackie.
No, so my question is, we talk about Medicare. I think a while back we talked about Medicaid. How do that?
Right, so this particular program is only available for the Medicare population. So nobody in this program has Medicaid. Medicaid is its own complicated thing.
Oh, okay.
But generally, Medicaid people in New York State don't have a choice to be fee-for-service.
Yeah, I was getting ready to say, what is it?
You have to join a
Right,
plan.
I was gonna say they don't have a choice.
Right.
That's the question.
I mean, in 2013, the creation of Medicare Advantage was because it was too politically difficult to say that Medicare recipients would be forced into managed care. It was politically unacceptable. Medicare people have a lot more clout than Medicaid people. And so the feeling was, okay, well, we can't make people do it, but we could attribute their lives retrospectively, right? So another important thing is everybody, all 6,500 people in this program have no idea they're in this program.
Yeah.
There's no membership, they're not told, it's all retrospective attribution. And that was done specifically so that those people didn't feel forced to go into something that they were not sure they wanted to go in. I think on the quality, as Matt was saying, it's difficult to focus on such a small population, and I think that's why we want all of our efforts to be high quality for everybody. We really don't want to be focusing on quality indicators for one segment. Because we have too many segments. It seems better for us to just say, for everybody, here are the initiatives. Occasionally, we have somebody who's a very high user. It makes sense to have something very targeted for them. But in general, we feel quality for everybody as opposed to trying, because as you know, each insurance plan, including Metro Plus and Health First, have different measures of what's quality, or sometimes they have the same measure, but different. One is on a calendar year. One wants you to get the mammogram in on the calendar year. Some want you to get it in a chronological year. And it's just too difficult. And it's not really who we should be. We should just be a high quality provider for everyone and not be so focused on each individual plan's requirements.
Okay.
All right, Matt, sorry.
So no problem. To take,
I do have, but I have another question. And did you get your question? No, you did not
No,
get
no,
your
I have a
question
different
answered.
question, but
Okay.
Shad, go ahead.
So okay, I'm new to this meeting. So am I reading this correctly? It was a $6 million savings? No. Yes? Yes, that got distributed. Okay, so just can you break it down more simply? What percent gets taken off before it goes to the facility?
it's about $1 million of admin.
Okay,
And then this year was our last time of
Okay.
putting any in. I think the total distribution is about 4 million
okay.
directly to the physicians this year. But happy to get you that breakdown.
No, that's fine. I just wanted to, I wasn't sure what it was, yeah.
Completed. I think we have filled up our reserves. We no longer need to fund that anymore. So
Okay.
next year's distribution will be a higher percentage.
Okay.
Yeah, happy about that. Frida, you had a question?
I didn't hear the discussion on the contract and just thinking about, so I guess our contract is up for renewal or has been renewed?
It's been renewed,
Oh,
yep.
it's been renewed,
Yep.
okay. And we have exit strategies, meaning,
You can leave at the end of any year. So if we had a year of bad performance and we felt the membership just got too small and we couldn't predict it, or we felt like this was a financial risk to us rather than financially advantageous, because again, we want to provide this quality wraparound care to everyone.
Right.
And so we're going to provide the care anyway. This program is helpfully a vehicle to get good data on these members and
yeah.
drive
But
some revenue.
given Mitch's comments on, the direction of where this might be going, and if we get smaller and smaller, it doesn't make sense anymore. So we do have, and there's no ramifications to getting out, because we're still taking the high-risk path.
Yeah, we are.
Yeah.
Yeah.
So we wouldn't want to be stuck, I guess, is.
Right, yeah. Luckily, we've put aside reserves over the past several years, so I think 1 or even 2 years of really difficult performance we could weather without there being a kind of net hit to the health and hospital system. But we watch it closely, and it's very important is to have those exit strategies to be able to leave the program quickly if it's not working for us.
Okay, thank you.
Sure. You have your next meeting waiting in the wings. So, maybe Dr. Cole, you can talk quickly about what each of the key populations are and where we're headed on this, but we have a busy agenda ahead, so we'll move rapidly for you.
Sure, I'll be very efficient, and thank you again for having us. So really, overview, these clinical projects are really focused on our utilization metrics, the 30-day readmission rates, and avoiding unplanned admissions for patients with multiple chronic conditions, because we feel our other metrics are very well supported by our pop health colleagues. So from an ACO strategy, clinical strategy, we're focused on those 2 utilization metrics, and the projects we're talking about really follow along on targeting that. So starting with CHF, the focus here has just been making sure patients discharged with CHF have a consistent, standardized level of care that is optimized regardless of which H&H facility they attend. So all the sub-projects are really based around 6 guiding principles: 3-day phone call, 14-day in-person appointment from the time of discharge. There are guideline-directed medical therapy, screening for social determinants of health, tracking mechanism, as well as hotline access, meaning they should be able to access members of their care team. And that's kind of where all of that comes from.
And just for folks to notice, congestive heart failure is one of the most common diagnoses we see in our emergency rooms and leads to admission. So this is an example of a program that starts in the ACO but would spread and hopefully have tremendous impact around the whole system.
Correct.
So just, Ken, getting to Mitch's point, though, so when you say for the ACO, we're trying to do this across the board, so how do we differentiate our ACO patients, specifically, let's say, with CHF and looking at their readmit rates? Are we basically looking at those, or is this a general policy now across the board?
So this is a policy that affects all our ACO patients and then some. So the idea with all our strategies is that they should cover all our ACO patients, but to Dr. Katz's points, they also cover our other vulnerable patients across. So we don't have to go through siloing which patients get which type of care. Our patients should get the same level of quality of care. So that's how we approach it. But of course, when we look at our measures, all of them affect our ACO patients. They just go beyond. For our frail elderly population, this is really just focused on the annual wellness visit. and ensuring a standardized visit that captures those high-risk geriatric conditions that may not be addressed in other subsequent visits. And the idea here was standardizing our clinical workflows and EPIC functionality to ensure that all those screenings as recommended by CMS, but we also know are important, cognition, fall risk, tobacco use, all of those are captured in that visit. And even if it's not brought up by the patient, we have to bring up because we know that comes. Asthma, the focus here is really to make sure patients are off albuterol monotherapy, which we know is associated with readmissions, and getting them on smart therapy controller medications, which we know prevents and reduces avoidable readmissions. High utilizer, we're just focused on our most vulnerable population, and here we just work with the facilities, making sure we're tracking those patients that have high readmission risks, and we follow these 3 metrics: the 3-day follow-up, 14-day call, and SUA screening. Kidney disease, delaying the progression of chronic kidney disease to end-stage renal disease, and working with our colleagues at Nephrology Council, Pop Health, to ensure we have all these different projects focused on that. Last, alcohol use disorder, very new project. The focus here is really supporting our patients who come to the ED with alcohol use disorder, which is a high source of avoidable readmissions, making sure we set them up with oral naltrexone pilots, and working with our addiction colleagues in the outpatient setting to make sure they're taken care of. That's it.
That's us. We're very pleased. Thank you for sticking with us and for your support over all the years. We look forward to continue to update you in another year of success next year.
And Matt, our $1 million projected earnings, is that because less patients more patients in Medicare Advantage than we're able to access? Why is the figure going down so significantly?
I'm sorry, which figure?
Sorry, did you project a 1.4 million of savings next year? Am I misreading it?
No, I think that is our savings per member that we're projecting so far.
Oh, okay.
And we have the fourth quarter of data to come. And then the thing that helps us at the end is ultimately regional adjustments, right? Our costs are still going up, but everybody else's costs are going up much faster than ours, despite our population being very vulnerable. A lot of dual eligibles, very low income population challenge. So that's us. Thank you so much.
Thank you so much. The meeting adjourned. Thank you so much.
Thank you.
This meeting is no longer being recorded.